perfect. So intra-atrial shunt creation in heart failure or for heart failure treatment. Just move on. So before I go to the topic of my presentation, I would just to mention this conference, which is conducted in Europe every year from CSI, which is not the Cardiac Society of India, it's the Congenital Structural Heart Intervention Society. And we have a dedicated congress about heart failure, device-based heart failure. And the reason why we initiated this is because this is really the next big wave for interventions, and this is interventions for heart failure. When we had this conference last time physically in 2019, we had more than 75 new technologies which had been presented at that one conference. So keep this in mind, please. So intra-atrial shunts, the creation of a small atrial septal defect to decompress the left atrium is the concept of this treatment. It's a new concept for patients with systolic or especially diastolic heart failure. An atrial septal defect, you all know, causes a left to right shunt. This causes right heart volume overload, pulmonary hypertension, right heart failure, all not good in patients who already have left heart failure, but there may be exceptions. So when could an ASD be beneficial in heart failure patients? If the ASD is small, it will not cause an increase in pulmonary artery pressure, but may result in a decrease of the left atrial pressure. Basically, the workload will be shifted from the diseased left ventricle to the healthy right ventricle. And this could be a concept, especially in patients with HFpEF, who do not have many other options. How the idea of creating an ASD in heart failure patients developed? Well, there is the Lutembacher syndrome, which is patients with mitral stenosis and a concomitant congenital ASD have less severe symptoms than patients without ASD. Also, ASDs have been created by ballooning in patients with mitral stenosis to relieve symptoms, and later ASDs had also been created in patients with other causes of left heart failure, including patients on ECMO. How to create an ASD, balloon dilatation, stents, and then several dedicated devices have been used to achieve this. And here you can see an overview about the different devices which are already available or in clinical trials. And you can see 3 devices here, which are devices which have to be implanted. They are made of nitinol. They have different diameters here between 5 and 10 millimeters. And they basically are implanted by a transeptal puncture. And then there are other devices which do not leave a device behind. There's, for example, the Venus Neuer system, which is currently in a clinical trial. They use radio frequency to ablate tissue. Then the intershunt and the Leviant, which are cutting devices which remove tissue in order to create an intra-atrial septal defect. This is the V-Wave Ventura intra-atrial shunt system, one of the first devices which have been used. You can see the conical shape of this device, which has a very small footprint on the intra-atrial septum. The diameter of this shunt is only 5 millimeters, but they use the kind of Venturi flow effect, which increases the flow due to this small defect. They also have here some exit hoods, which prevent or hopefully prevent paradoxical embolism. They have an PTFE encapsulating of the entire device, which reduces the likelihood of tissue ingrow, which could make the defect smaller over time. So this is the Corvial, this is the Corvial device, which is again inserted by transeptal puncture. It has an 8 millimeter shunt device. It has a very low profile of the left side of the device. This is the right side of the device, and this has adjustable anchors or legs which adjust to the anatomy of the intra-atrial septum if you do the puncture close to a thicker part of the intra-atrial septum. And then we have the Occlutech AFR, atrial flow regulator, which is designed like the ASD or PFO devices from that company. They have a flexible connection between the delivery and cable and device, and the delivery cable is actually mounted to this ball here, which means it's repositionable and it's even retrievable. So if you implant this device and after 1 or 2, 3 days, you see, okay, this is not good for this particular patient, then you can go in with a snare and retrieve it completely. Potential indications of this particular device, as already discussed, left atrial congestion like diastolic and systolic heart failure, but it has also been used a lot in right atrial congestion like patients with heart failure due to pulmonary hypertension, and it has also been used in some congenital heart defects. This shows you an example of the implantation. You can see the fluoroscopy. It's implanted like an ASD device. You can see the device in the septum, and this is the flow going through the device. Then we come to the NOIA radiofrequency interatrial shunt system. As mentioned before, this is ablation by radiofrequency energy. It has an adjustable shunt size, so you can insert the device after transeptal puncture. You open the distal part, you open the proximal part, and then you can adjust the size of this waist here according to the individual need of that patient. Then you apply radiofrequency, and you can create defects between 4 and maximum 14 millimeters. These are pictures from the animal trials. This shows you 6 months follow-up. You can see that these holes do not close over time. And then we have the InterShunt, which is a cutting device. So you do the transeptal puncture, you insert this device up to the level of the interatrial septum, and then the distal part of the device is pulled back to the septum, and then the cutting device is activated, and the sheath is advanced over the cutting. So that means all the tissue is kept inside of the catheter, and then you can remove the device. The Eleviant is the other cutting device, which uses actually radio frequency to cut out a piece of tissue. It creates a shunt diameter of 7 millimeters. These are images from the 6 month follow-up trial, 6 months first in human trial, and you can see that the diameter of these defects remain constant over time. Is always the left elevated left atrial pressure, and this is something which is true for all forms of heart failure. It's created by sympathetic activity, which then results in fluid retention, which is the slow mechanism of increased LAP pressure, or by venous redistribution. This is more the effect in diastolic heart failure, and this finally results in lung congestion. And it has been shown that the increased left atrial pressure is actually the first sign of decompensation to choose this as a target for a device to treat heart failure. So regardless of left ejection fraction, of the LV ejection fraction, it's always the increase of left atrial pressure which causes decompensation in heart failure patients. The concept is a small shunt can regulate the LA pressure in HFpEF and in HFrEF, and when the LA pressure rises, the shunt flow increases, lowering the left atrial pressure. So an interatrial shunt kind of auto-regulates the left atrial pressure 24/7. This has been tested in animal models. This is in an animal model for ischemic systolic heart failure, and you can see they had a control group and a treatment group, and you can see the long-term improvement up to 12 weeks regarding various parameters in this preclinical trial. The first reduced LAP-HF trial was a prospective non-randomized study including 64 patients. In this study, only patients with preserved ejection fraction had been included. You can see the inclusion parameter assessment was done by an independent core laboratory, and they are planning for a 3-year follow-up. It basically showed that there was significant improvement in heart failure class, in 6-minute walk test, as well as in quality of life and in exercise time. These are results with the VWAVE trial, the pilot study results, and you can see again shunting improved functional outcomes in HFrEF and in HFpEF, quality of life, heart failure class, and 6-minute walk test improved. And these are data from the AFR device from Occlutech, where you also can see improvement in functional outcomes in HFrEF and in HFpEF patients. So when you look at all these different clinical trials, there was a striking consistency across multiple devices and trials demonstrating a high implant success rate, excellent procedural and device safety, improvements in heart failure class, quality of life, and 6-minute walk test, and low rates of mortality and heart failure hospitalization, suggesting an impact on clinical outcomes. Again, this is our heart failure conference. Thank you very much for your attention.
I have actually two important questions which audience would like to know. One thing is, in your personal opinion, which kind of patients and what stage of heart failure management would you think that is really going to help patients? That is my first question. Yeah. And the second one is the related one, actually. And do you think any specific advantage in patients with hypertrophic cardiomyopathy?
Both are good questions. So first question is, we have most of the data is coming from patients with preserved ejection fraction, diastolic heart failure. I think the ideal candidate is somebody who has heart failure class 3, maybe 2, but most of the patients have heart failure class 3. So this is currently the best indication, but as I mentioned in my talk, I believe that it will also work in systolic heart failure. In hypertrophic cardiomyopathy, I think that is a good indication. I mean, we're talking about non-obstructive hypertrophic cardiomyopathy, as well as in patients like patients with amyloidosis. They respond very well to this. They have very stiff myocardium, and if you decompress the left atrium, that helps them a lot. So these are actually good indications currently, and I'm sure that we will also move on to patients with systolic heart failure.
Horst, Dr. Hazra here. When you test these people on the table, their LA pressure, they are lying down. But most of these patients, they get symptom not on lying down. When they walk, their gravity,
well, we separate the diagnostic study from the treatment. So we do a diagnostic study first, and what is very important to exercise them.
You are muted, Horst. You're muted. You're muted. Yeah.
Okay. So we separate diagnostic study from the treatment. So we do a diagnostic study first, and we measure the PC wedge pressure, and it's important to exercise the patient on the table, because many of them have, especially those with diastolic heart failure, as you know, they have borderline pressure or normal pressure at rest, but when you exercise them, then pressure goes up. And sometimes in many patients, actually, if you just raise the legs, that increases the LA pressure. So this is the diagnostic study, and we have certain criteria when to include a patient or not. But then during the treatment, we don't do this test again. We just implant the device. But if the LA pressure is elevated at rest, then you can see the immediate decrease during the procedure.
Right. So if you have said that sympathetic system plays an important role in hemodynamics, if you have a patient who has got RDN, like renal denervations, or Getter-Splanchny numb or Splanchny numb denervations, or heart failure, do you think that the sympatholytic agents or beta blocker and these denervations will complement or blunt the response of the shunt?
Well, we haven't done a shunt implantation in patient who had renal denervation. I mean, the renal denervation for treatment of heart failure is just coming. We need, I'm sure it will be effective, but we need many more data and more trials before this can be used in clinical practice. It can be used for hypertension, but heart failure is just coming. I mean, it's independent. When the LA pressure is high, and of course the RA pressure is low, then the patient will benefit, regardless whether any other procedure has been done before, whether the patient is on medical treatment or not. As soon as you decompress the left atrium, patient will benefit.
Thank you.